everyone. For those that don't know me, my name is Jessica Nielsen. I'm the president and founder of the Psychedelic Society of Minnesota. I'm also the chairperson for the state psychedelic medicine task force. And up until May, I was a tenure track assistant professor at the University of Minnesota doing clinical trials with psilocybin, amongst other things. And so just want to preface the fact that I am speaking for myself, and not necessarily, any of those roles that I just mentioned or the institutions. But I am feeling called as sort of the president of the Psychedelic Society here in Minnesota to talk about some recent developments in the psychedelic space. And I just want to let everyone know that I'm going to be dedicating a lot more time to the psychedelic community now that I've left my tenure track position in academia, and really more interested in focusing on policy work with the task force and grassroots community research and education and harm reduction. And and so there's just been a lot going on recently that I feel compelled to talk about and just let the community know kind of what's actually going on in the psychedelic space, because there's a lot of stuff being talked about in the media with, MDMA for post-traumatic stress disorder being reviewed by the Food and Drug Administration for potential approval, and rescheduling and legalization of MDMA assisted therapy for PTSD, and some updates around the FDA not viewing what was submitted by that company, formerly MAPS Public Benefit Corporation, and not viewing it favorably enough to potentially approve. We'll have an official answer in August on that, but it's sort of an interesting landscape that, a lot of what the psychedelic boom or the psychedelic renaissance or this, more recent surge in the last couple of decades of interest in psychedelics is, a lot of that has been spearheaded by the Multidisciplinary Association for Psychedelic Studies and their efforts to, legalize MDMA. For those that don't know the story of it, it was kind of being used a lot in the 70s and 80s by therapists to treat trauma and for couples therapy, and therapists recognized its value. But it's also a fun drug that people like to take. So, when the party scene gets a hold of something, the saying is, if it's fun, put it on Schedule 1. And that's like a whole nother topic I want to talk about, is the drug scheduling system and what is legal. Because there's a lot of policy things going on around the country, with Oregon having this kind of like quasi-legal system where you can go there and take psilocybin with a licensed facilitator for a hefty fee. But that's now an option it's legal in Oregon. It's not federally legal. Colorado passed a similar thing with some notable differences. And there's just a lot of efforts in the state, in the nation, and different states to change policy around psychedelics and whether they have therapeutic potential. And so getting back to the FDA clinical trial, or the FDA, evaluation of MDMA for PTSD, I think there was a lot of excitement that, wow, these things are on track to be approved by the FDA. And we're seeing, rightly so, a healthy amount of skepticism about the data that's been coming out of these trials. And I think the results are amazing. The effect sizes, so this is basically a statistical term to say, like, how much did this treatment move the needle compared to another treatment or to a control or to some earlier assessment. And so, I think folks are doing their best to try and push psychedelics and things like MDMA through this clinical trial pipeline to demonstrate that they have some therapeutic value. Because just quick rundown of the Controlled Substances Act, it's currently a Schedule 1 drug, as are most other psychedelics, currently cannabis, although that's going to be rescheduled to Schedule 3 because of recommendations from FDA and HHS, which is the Human Health Services branch of the federal government. So if something's on Schedule 1, it's considered to be dangerous, has like high abuse potential, causes a lot of harm, and has no medical uses. Whereas the other schedules 2 through 5, are regulated somewhat differently depending on schedule. So Schedule 2 would be things like cocaine and methamphetamine. These are Schedule 2 because they have some uses. In medicine, Schedule 2 is a lot more tightly regulated, probably closer to how Schedule 1 is regulated, but people can prescribe it, whereas Schedules 3 through 5, are a little bit more lenient in terms of enforcement and consequences for diversion, as it's called when you sort of give supply to other people that you're not authorized to, outside of getting a prescription. So in order to determine whether something has therapeutic potential, the FDA needs to see results from these clinical trials to say, okay, this drug is not harmful, it's safe, and it has some indication to help alleviate suffering for a specific condition or multiple conditions. And if that's determined, then the FDA can then make a recommendation to the Drug Enforcement Agency to say this should not be on Schedule 1. And so that happens when you have FDA approval. And so a lot of us thought this is a shoo-in. They followed all the rules. They designed a double-blind, placebo-controlled, randomized clinical trial, recruited hundreds of people. But there's just some fundamental methodological caveats and confounds with the way that drugs like MDMA, psilocybin, and other psychedelics work, and the way that you have to test what's called efficacy, which is how much better does this drug increase or decrease symptoms of a disease compared to a placebo control. And the idea is that people are enrolled into these trials and they don't know which drug they're going to get. They could get the placebo or the comparison group drug, or they could get the active drug or the MDMA or the psilocybin or whatever. And theoretically, they shouldn't know, and the effects of what they're feeling sort of physiologically shouldn't be a dead giveaway of which group they're in, right? So a lot of times we have placebo controls because, for example, in depression trials, there is an already 40% placebo effect just from being in the trial. So if people expect that they will get better, 40% will get better, I think, is a statistic. I need to double check that, but it's a pretty high number. And there's a reason we have these controls, so that any kind of bias from either the people doing the experiment, collecting the data and analyzing it and coming up with these conclusions, or the people that are being experimented on in the trials, and what do they actually believe is happening to them. And if they really believe that they're getting better, then they might answer the questions around, especially with mental health, where a lot of it is subjective. It's what does the person tell you? How do they feel? Versus measuring something objective, like what is this doing to somebody's heart rate or something else that is not as easy to have a placebo effect. I'm getting off track, but so the problem with things that induce these really intense mind-altering experiences is it's pretty obvious very quickly which group people are in, both to the people taking the drug and to the people observing them while they're on the drug. So the blind is almost impossible. And so they call this functional unblinding, and it's, a big wrench in this system of trying to demonstrate whether this drug works better than a placebo. So it's unclear whether that will tank the FDA's consideration of this, given the effect sizes and just how much larger they are than other standard lines of treatment, like antidepressants and cognitive behavioral therapy. I really hope FDA does approve it. I mean, I think by and large we know it's safe, and whether it can treat something, I think, shouldn't preclude something from staying on Schedule 1. I think Schedule 1 should be reserved for things that are truly dangerous, that like kill people, and that, really almost are like poison. Like it should be kind of working with poison control, and I think that happens to an extent. And I bring that up because there are things out there that are harmful that the FDA puts out warnings about, but then they don't put it on Schedule 1. So it's just an interesting thing of like, well, there are some things, and it seems that if people really want to use them a lot, like, recreational drugs, that people use either for recreation or not. That's their choice. But it seems like that is what triggers something being on Schedule One. And I'm not a lawyer, and I don't claim to be an expert on the Controlled Substances Act, but I've had to learn a lot of it recently for just my work with the Psychedelic Task Force and trying to figure out like what are the statutes, how are these things enforced, what's the difference between federal law and state law, and I can do a whole separate video about that. But I just feel like the whole concept of Schedule One is not evidence-based, because things get put on Schedule One for very little reasons, just that there's this fear that it's causing harm and that it has a high potential for abuse. But I don't think whether it has therapeutic potential should be justification for something being on Schedule One. If all the evidence that you can look at says overwhelmingly this is not dangerous to the public, at least not as much as some other things in other schedules, even alcohol, which isn't scheduled at all. It was exempted from the Controlled Substances Act because it's something that we've just kind of accepted as something people want very much and will revolt if they can't have it. And we just need to kind of set social guardrails around what is acceptable behavior when people are intoxicated on that substance. So something similar could happen with psychedelics. They are quite intense, but it's not that, people that want people to have access to these substances are encouraging folks to drive around and, be bus drivers or whatever, or, anything that would put other people at risk. People take lots of things to alter their consciousness and to explore their health and their wellness and their spirituality. And it really shouldn't be the role of the government to tell people what they can do with their own bodies. So having said all that, I just wanted to let folks know that there will be more content coming down the pipeline now that I have more capacity, now that I'm not doing clinical trials anymore. That did take up a lot of my time and energy, and it made it hard to focus on psychedelic society stuff. So I just want folks to know that I'm here, and I'm going to be hosting more events and creating more content and really trying to make Minnesotans more aware of what's happening in the psychedelic space as the Psychedelic Medicine Task Force progresses and as new clinical trials emerge across the country and new states legalize things, and as things progress. And I think it's important to keep everyone informed, and I appreciate your attention, and send us any requests at psychedelicmn@gmail.com, or in the comments if you have requests for specific content that you'd want some more information about. Happy to try to track down the information to create that for everyone, because the main focus of the Psychedelic Society is really about education and harm reduction and building community around psychedelics. And so I'm here for that, and thanks for listening. Have a good day.